Hello. Okay. Hey, everybody. My name is Caroline Clutton. I'm a second-year medical student at the University of South Alabama down in Mobile. And today I'm going to talk with you guys a little bit about my project on patient-reported outcomes and how they can provide qualitative insight into patient conditions here, specifically in trauma patients. So we're really interested in more qualitative outcomes because we have a lot of information on like surgical success and like those kind of outcomes, but we don't have a lot about how patients are and how they're returning back to their normal life after trauma. So that's what the goal of this project was. And to do that, we took all trauma patients admitted to South's Level 1 Trauma Center between December 2022 and February 2023. And that kind of at the time when I was collecting the data gave us about 6 months out. So it gave the patients time to kind of return to their normal life or attempt to. And then from that, we have some exclusion and inclusion criteria. So 18 years of age or older, we want a GCS of 15 or greater or not greater on arrival. And then English speaking, these were mostly just for ease of the actual survey administration. And then I called a lot of patients and talked with them and gave them a 12 question questionnaire. And those 12 questions came from different places. So the EQ5D, and you'll see these on the charts in the middle. We have EQ5D, that's a 5-question survey assessing mobility and how they're like able to return to their activities. The CTM3 is a 3-question survey, and that's assessing how they perceived their readiness for discharge. And then the last one is the PROMIS. There's a bunch of different surveys within PROMIS. We use the social section, so that kind of was gauging how they're able to return to their social relationships post-trauma. And then for like ease of the like statistical analysis and all that, I did assign numbers to the answers. So the lower numbers here denote better outcomes for the patients. So we have a couple significant results. The first one was in our CTM3 in the difference between white and Black patients. We actually see that Black patients significantly felt less prepared for discharge. So that's super interesting and not exactly what we want, but interesting to know. And then the other thing that is very like significant for us is the difference in our EQ5D, which is our mobility assessment. And that was had the greatest difference between the self-pay. I guess I could use the laser. It had the greatest difference up here between our self-pay and our Medicare. That was the biggest, with self-pay having worse outcomes of the two. So we also did it based on mechanism of trauma. We did it on all the different insurance, race, and then over here on this pot, we have like their scores with age and scores with lengths of stay in the hospital. And we actually found with none of the rest of those did we find any significant difference, which is pretty interesting. I personally thought age would play a bigger role than it seemed to in our data. So yeah, overall, we found those couple differences. This is super interesting. It's like very kind of new, and we're going to try to use this information to better like apply discharge strategies. So not a one size fits all. And then also it's kind of maybe it could be obvious that insurance plays a role because the more access to like different services within the hospital before you leave would make you feel better about discharge and also would give you a little bit more like mobility before you even leave the doors. So that kind of makes sense, but we're just using this as like a preliminary, can we use these measures as a way to like find data that's useful? And also how can we use these numbers now in our specific facilities to kind of like alleviate discrepancies? So yeah, if anybody has any questions. Will you? Yeah, so the biggest thing for me was like, we had about 300 patients that qualified, and then with the inclusion criteria, got us down to like 180. The hardest part was getting the people to answer the phones, and because I'm doing this a phone survey. And also, I had a couple once they answered the phone deny, but most of the time, if they picked up, they were like going to complete it. So yeah, it's a super small sample size and it's really truly like half the numbers are disconnected and like a lot of people don't answer when the hospital's calling. They think it's like the billing department. So that was the biggest issue. And like, of course, we'd like to get bigger numbers on this, but that is what we were working with. I will be so honest, I did not run the stats. I'm not a big stats girl. We had our like trauma stats guy run and give me the numbers. Yeah. Yeah, I think a lot of it could be in our database, like disconnected phone numbers, incorrect phone numbers, like that kind of thing. Also, with the timing that I had to do the project, it was like I could have reached out 6 times to everybody and like really hammered in. The time frame could have helped. I could have had a little bit more time to reach out, but I don't know that like emailing a form or anything would be better because I honestly don't think that would get better responses. So that's a great question. I don't know, honestly. Because it's 6 months out too, like there's not a good way to really get a hold of patients if they don't want to be, you know, answering. Thank you.